Upon the chairpersons, Dr. G.S. Sinha sir, Dr. Kapil Kulshresh sir and Dr. Tribhuvan Singh sir to kindly come on the stage. And our speaker for the next session will be Dr. Kumar. I request the chairpersons to kindly introduce her.
She is fellow, WHO fellow, National Awardee for Science and Technology Communications. She is past associate editor of Indian Journal of Rheumatology. She is editor of Skin and Rheumatologic Disorders, and she is past president Delhi Dermatological Association. She will be speaking on the topic of low back pain. Now I invite Dr. Professor AMACON to deliver her lecture.
Association, Dr. Subodh Jain and his team for inviting me, and special thanks to Dr. Anubha, who has actually connected me once again with Allahabad. So thank you so much, Dr. Anubha. And it's been a wonderful meeting, and the hall is like, I was telling my colleague, it feels like I'm sitting in the PVR of Delhi. So it's so good. And as Sir was telling, I am a product of Allahabad Motilal Nehru Medical College, and I say it so proudly. Mine was 85 batch, and yesterday I went to see my hostel, my mess, and the whole campus. So it was very nostalgic. I was overwhelmed, and the warm hospitality which has been extended to me. So I'm fumbling. I didn't know that this is for the students if they are there. When I was here in Motilal Nehru, I didn't know that I'll reach where I am today. And कहते हैं ना, जब नींव मजबूत होती है तो you can stand tall. So I joined AIMS in 1995, and since then I'm here, joined as resident, and I'm now heading the department, created the Department of Rheumatology at AIMS New Delhi. So today I have no disclosures. I have no conflict of interest. We are talking about back pain, which happens to be so common manifestation in itself without any existent disease. Any specialty comes up with a patient who has back pain. And I'm sure everyone sitting out here would have had experienced back pain sometime or the other, because we know these days we are talking about workplace ergonomics. The way we sit, the way we spend our entire day influences our life, and the pains and aches are the byproduct of success sometimes of the failure. So back pain is not only simple pain, but it disturbs the patient's quality of life, which we have all seen. It adds to the medical cost, and it limits the patient's daily activities, and ends up landing patient with psychiatrists, sometimes with depression and other psychological issues. And when it's upper back, it's not much of a problem, because when there is a pain in the upper back, we usually find some etiology for it. But when is the low back pain, often we do not find any cause for it. And this is good that 60 to 80% people, they experience pain, but more than 95%, they have only mechanical pain. What is mechanical pain? I'll dwell upon that later. And out of all the patients, 90 to 95%, they recover completely within 6 to 8 weeks. But 40% patients, they do relapse. And there are various factors which are responsible for relapse of back pain. And advice of back rest and advice of various assist devices or belts, back belts to patients also contributes to the relapse of symptoms, because they want absenteeism from work and then they malinger or feign their illness. Only 5% of the patients, they are known to have inflammatory low back pain. Quite often we find that it's written lumbar strain, lumbar sprain, or lumbar lordosis or lumbar spondylosis, because we do not have any diagnosis to give to the patient. So, but nothing to worry about. It's simple, explaining to the patient many a time works wonder, and even relapses are reduced, studies say so. Back pain is not only with having nociceptive, my slide has got some altered, nociceptive stimulus or neuropathic stimulus. These days we are talking about third pain, which is also called nociceptive pain, where the pain pathways, they play a great role in processing the information which is not actually arising from the tissues which are injured or the nerves which are involved. And the classic example of that is fibromyalgia. I'm sure you would have heard about it. As I said, 95% patients have mechanical back pain. Herniated disc contributed only by 4%. Subsequently, during my presentation, I'll show you, but the abnormality in disc was found in more than 50-60% patients on MRI. Spinal stenosis, osteoporotic fractures, spondylolisthesis, and workplace ergonomics, as I was talking about, which increases the early degeneration of our vertebral joints. Under non-mechanical, we have cancers, infections, and spondyloarthritis. Spondyloarthritis is one diagnosis which people love to make, and many a time when patient comes to us telling that he is having ankylosing spondylitis, because ankylosing spondylitis these days is like death sentence. When patient is completely ankylosed and fulfilling the criteria for ankylosing spondylitis, then only we label that as AS. Otherwise, we call this axial spondyloarthritis. And then we know that referred pain can also be in the back. So to differentiate between inflammatory back pain and mechanical back pain or non-inflammatory back pain, we have to keep in mind certain points. Inflammatory back pain is always precipitated by rest. When patient wakes up in the morning, has stiff back which lasts for more than 30 minutes, or patient has night pain, wakes up in the middle of the night when turning on the bed with pain. Non-inflammatory usually is, there's something called gelling phenomena, where again patient can have pain following prolonged periods of sitting or resting, but that lasts only for 5 to 10 minutes. So usually that mechanical pain comes with activity. Pain gets better with activity in inflammatory, but gets worse in mechanical. Diurnal variation, obviously, after prolonged activity when we are talking about, so it would be more in the morning, and mechanical pain is usually after activity, so maybe after some activity or towards the evening. Constitutional features we are going to get in inflammatory back pain, because there is one inflammatory condition which is associated, like in axial spondyloarthritis, which we are talking about. So patient can have feeling of fever, not really fever. Patient can have a bit of weight loss, can have fatigue. These are all signs of ongoing inflammation in the body, but not in the mechanical back pain. On radiographs, yes, we might find some changes on X-ray in inflammatory arthritis as well as in mechanical, but both are very different. Examples of both, yes, osteoarthritis, degenerative disease in mechanical, and spondyloarthritis or rheumatoid arthritis, or for lupus, any inflammatory condition, be it immune inflammatory or infection or malignancy, can result in that. There are criteria for diagnosing inflammatory low back pain. It's just shown you Callan's criteria. There is ASAS, which is an assessment in spondyloarthritis study criteria, like age of onset usually is less than 40 years, back pain more than 3 months duration, usually has insidious onset, and it improves with exercise and more in the morning. So if patient fulfills 4 out of 5, we say this is inflammatory low back pain. So when the patient comes to us with back pain, as I told you, acute and subacute, usually 90 to 95% patients, they spontaneously get better. But keeping the patient's age in mind, if patient is in 60s or 70, a lady or a male, depending on that, we can think of osteoporosis, which is thought to be the silent disease, but if the patient has microfracture or fracture, there could be back pain. Certain malignancies with metastasis can manifest with back pain. So that is to be kept in mind. The aggravating relieving factor, as I told you, and it's very important to know what is the psychological status of the patient. There are some patients who have various kinds of problems in their lives, in the family, or as I was hearing in the morning, some patients can have psychiatric issues, but they keep complaining about it. They go back and read on the Google, and then exactly the way it's written they present in the OPD, and it becomes clinically very difficult to make out whether patient is having inflammatory low back pain or not. So patients are also smarter, so we have to be more smarter than them to actually give them a label. There are certain red flags. So that history is very important in all the patients whoever are coming to us. This is like history of fever. My slides are getting altered actually in this projection, I don't know, but I think it's readable from the distance, right? A patient has history of fever, unexplained weight loss, patient has history of some drug abuse, history suggestive of any chronic infection, cancer. Some patients can just have nodular swellings over legs and having back pain and ankle arthritis. I'll come up with some examples also. So then we have to think of some organic condition. Psoriasis is to be specifically looked at. Patient may not complain, or if the patient has history of psoriasis in the family and patient is coming to us with history suggestive of inflammatory back pain, then we can think of psoriatic arthritis, spondyloarthritis types. And then red eye or uveitis, scleritis, conjunctivitis. So eye issues are to be looked at. A patient can have pseudo-claudication. If the pain is radiating, that's like radicular pain, then one has to be very careful. So these are some of the red flags. Or patient has history suggestive of inflammatory bowel disease, be it Crohn's disease or IBD, and then back pain, then one has to be careful. Here I would like to tell you that not all patients at the very beginning develop sacroiliitis. So that is not the mandatory criteria for diagnosing these patients with spondyloarthritis. Other pointers are also to be taken care of. And studies have shown that progression to develop sacroiliitis, that is somewhere to the tune of 11% every 2 years. So by 10 years, we expect 70 to 80% patients having sacroiliitis on radiograph. These things are also very important, and they are called red flags because they also help you in diagnosing patients and managing the patient further, how to treat and how not to treat, and how extensive we are to be to investigate these patients. Because many a time when patient comes to us is carrying bunches of radiographs, MRIs, CT scan and whatnot. So those investigations are to be avoided as much as possible if not indicated in patients. So when we examine these patients who have come up with back pain, there's something called GALS, like we see the gait of the patient, how is patient standing. When we ask patient to walk, patient might kind of to show that is in great pain, can walk in stooped forward posture, but when the patient enters our clinic, may not be so careful, so they may not be able to feign the illness at that point of time. So the observation starts at that point only. Then arms, when we say all joints, shoulder, elbow, wrist, hand, nail. Even the nail examination is very important. Patient is complaining of back pain and we find nail changes suggestive of psoriasis, then we can have some impression like it could be spondyloarthritis, which is psoriatic related. Then it's also very important to examine the skin in very much details. That can give us lots of clues to the diagnosis in patients. So just to remember, it is GALS, gait, arms, legs, spine and skin. And examination in rheumatology, what we follow is inspect, feel and move. So as is the teaching had been, like when we used to go to our wards, medicine ward, and our postgraduates, they used to got hold of us and then used to teach us, and we sometimes it had happened that we tried to looking at particular postgraduate in the department, we used to run off, but that teaching has actually helped us and in getting to where we are. So all thanks to the people who are known and who are unknown. I really don't remember many names. So inspection is vertebral deformity, peripheral arthritis, psoriatic skin changes, cafe spots, hairy patches, but spina bifida can also result in back pain, abdominal fullness for referred pain. So I mean, we have to do detailed clinical examination even if patient is not complaining about particular problem. Feeling is feeling the joint and feeling the bone. Suppose we pressed over the bone and we found that patient has bony tenderness and patient has come up with back pain. Then the teaching was that patient can have malignancy, lymphoreticular malignancy, or patient can have multiple myeloma. Even in osteomalacia, patient can have pain over the bones. So all those things are very, very important. Then movement is something called benign joint hypermobility syndrome, where patient has hypermobile joints and feels pain at all the parts of the body, and fibromyalgia is also very commonly associated with this condition, and where patient does not have any inflammatory arthritis but still feels pain in many joints and also in the back. Just to take the case scenario where 35-year-old obese male, he was a call center employee, complained of low back pain. So at the very outset, it's important to differentiate between inflammatory low back pain and non-inflammatory low back pain. So this patient indeed had inflammatory low back pain, used to have in the morning, and then lasted for 30 minutes, more than 30 minutes, and then it used to get little better with activity. The patient felt better in the afternoon, and modified Schwarber's test was positive. ESR was normal. CRP was bit elevated, and all of you would be knowing that CRP can be elevated even in obesity. So X-ray was normal, but HLA-B27 turned out to be positive. So even here we can think of a condition called axial spondyloarthritis, where we did the MRI and we found that patient had bilateral sacroiliitis on MRI. This is called non-radiographic spondyloarthritis. So HLA-B27 does not always mean that patient has some kind of spondyloarthritis. It can be positive in 6 to 7% of the normal healthy individuals. So making a proper differential at the outset is very, very important. Just a word about spondyloarthritis. This is an interrelated group of rheumatic diseases which share clinical, imaging and genetic features. Like they all have inflammatory back pain. There would be peripheral arthritis, which is usually asymmetrical, oligoarticular, predominantly lower limb, large joint involvement, anthesitis, extraarticular manifestations in form of uveitis, and sacroiliitis, familial clustering, HLA-B27 association. It was called seronegative spondyloarthropathy initially long ago because rheumatoid factor was negative, but that terminology has been struck off. So there are many, many conditions included. If it is occurring in a child who is less than 16 years of age, that becomes juvenile spondyloarthritis. There could be IBD associated spondyloarthritis, reactive arthritis, which is, you used to call it Ritter's also, psoriatic arthritis, etc. There are classification criteria for axial SPA and peripheral SPA. We call it as spondyloarthritis. So, but you remember in rheumatology we have only classification criteria, not diagnostic criteria. So these and we all know classification criteria are meant for patients to be recruited in various clinical trials to maintain the homogeneity. In our clinical practice, we do not wait for patient to satisfy those criteria to diagnose. So clinical impression is very, very important, and rheumatology is like pure clinical medicines where investigations contribute only by 5%. This is just to show you that this is a group where X-ray would be normal but MRI would show sacroiliitis and patient would be manifesting with inflammatory back pain. So we call it non-radiographic axial spondyloarthritis. And then gradually patient progresses to ankylosing spondylitis when he starts satisfying this modified New York criteria 1984, and we do not want our patients to get fixed to these criteria now. So there's another case. It was 26-year-old male patient who came up with back pain of 6 months duration, had ankle arthritis on examination, anterior uveitis history was there. So how many of you would think that this patient has spondyloarthritis? Raise your hands please. Yeah, I could see few hands raised. So this patient, ESR CRP was elevated, and since X-ray pelvis was, as I said, can be normal, so it was normal, HLA-B27 negative. So any patient, look, these rheumatological illnesses are diagnoses of exclusion because there are no diagnostic criteria, there are no diagnostic tests, right? So in this patient had ankle arthritis, has anterior uveitis and back pain, which can all happen in spondyloarthritis, but can happen in other clinical conditions as well. So we thought of sarcoidosis also in this patient because history was very short, and then all three things occurring together, ankle arthritis. We have few differentials like this: sarcoid, tuberculosis, leprosy, spondyloarthritis, gout. These are some of the examples when we think of only ankle arthritis. So this patient had bilateral hilar adenopathy and had sarcoidosis, not spondyloarthritis. So then another patient was a 50-year-old male patient, again had back pain, and sometimes in 20% of the patients there could be confusion between mechanical and inflammatory. We may not be able to make out. This patient had back pain, knee arthritis, 1 year duration, and hip pain of 1 year duration. ESR CRP normal, HLA-B27 is positive, and X-ray DL spine I'll not show you. So how many of you think that this patient had spondyloarthritis as a, how would you keep spondyloarthritis as the first diagnosis? Anyone? None. Oh, very good. So because here the age of the patient is 50 years and disease is happening for post 45 years of age. So usually what happens, spondyloarthritis occurs in individuals less than 45 years of age. So age is more, but age is no exception. So we look what we found on X-ray DL spine. There is ossification of intervertebral disc space. So this patient had ochronosis, not spondyloarthritis, despite having back pain. Then there is another patient, this is a female, and these disorders are more common in females, we know, back pain, but inflammatory low back pain is more common in males. Patient had low back pain which was inflammatory, and patient also had heel pain. So initially this particular lady, I remember, was thought of as having, because she had delivered, it was told that because post delivery she had undergone cesarean section, and so pain is because of that. But it kept increasing. She landed up with us, and we did investigation, ESR CRP elevated. I was told by my gynecologist that ESR CRP can be elevated in peripartum stage also. So but we went ahead with, despite HLA being negative, we did MRI and we could find patient had bilateral sacroiliitis. But remember that in peripartum state or postpartum also patient can have some sacroiliac changes, and there are criteria to say when to label patient as having sacroiliitis. So detailed history and examination is indispensable in diagnosing back pain. And about investigations, we have to be very, very careful. We always do routine investigations in patients who are coming to us with back pain, like hemogram, LFT, KFT, serum calcium, phosphate, vitamin D levels, right? Only this much. If there is no other history suggestive of any other disorder, we did not find anything on examination, right? So, and then we treat these patients, give them counseling. But if we find any clue towards like patient has red flags, and then we go ahead with radiography, and X-ray may be normal, and if you are actually thinking about, as I told you, non-radiographic SPA, then we can do MRI, or if there are some red flags, then appropriate imaging can be ordered in these patients. But it shouldn't be like patient came up with back pain and this is ordered. CT, MRI both have similar accuracy in detecting herniated disc and spinal stenosis, but MRI is more sensitive for detecting infections, metastatic cancers and tumors, and also non-radiographic axial SPA. So it's important to remember that imaging can be used to help confirm a clinical diagnosis, but we need to have differential diagnosis. We need to know what we are going to look for, but cannot confirm that a particular structure is the cause of patient's pain. And do not advise radiological investigations to non-specific low back pain if it produces more confusion than it adds to the cause. Patient will keep on doing doctor shopping, and you'll end up losing a patient because patient will not understand why he's having pain. This was a study where we could find that Here the normal volunteers, healthy volunteers were recruited and MRI was done, and you can see in this table that so many various kinds of abnormalities were found on MRI, starting from herniated disc to bulging disc to degenerative disc, stenosis and all, but they were all healthy, normal people. They did not have any symptom. So this only proves that we should not do investigations inappropriately. We have to be a little more careful in older adults, as I told you. So the take home is that 90 to 95% of the low back pain patients, they recover within 2 months. 85% low back pain, they go undiagnosed in the best hands. So don't be worried about if you're not getting any clue towards the diagnosis. That is to be explained to the patient. The probability that a low back pain has a specific cause is only 0.2%, right, in the best of the centers. Only 5% have inflammatory low back pain. Identifying red flags and yellow flags early at the very outset is very, very important. Order radiological investigation judiciously and interpret carefully. Rehabilitation of the patient is very, very important. Thank you so much for your patient hearing.
Thank you, Dr. Uma, for giving us a wonderful presentation on backache. It's very most difficult problem and most difficult how to approach it. But I think you have done wonderful job in giving such a beautiful account in such a limited period of time.
Thank you.
I think there would be many questions. Can we allow one or two?
Yeah.
Madam, there are cases of the chronic low back pain which are psychological in nature. How to deal with them?
I missed the question because he was introducing the Sir, please, could you please repeat the question?
Chronic low back pain,
Yes.
psychogenic or malingering in nature.
Mm-hmm.
How to deal with them?
How to deal with them? I think giving them the psychological counseling, putting the picture very straight in a very diplomatic manner, and telling them they do indeed have problem. They are not, well, that's what I do, I'm telling you. They are not malingering, but it's not always there's some problem with the organ or the structure or in the joint or in the back. Sometimes when brain is processing that information which is coming from the periphery, जो आ रही है, मैं तो कहती हूँ तो होता होगा शायद हवा चल रही है तो हवा भी आपको दर्द की तरह लगती होगी, तो पेशेंट कहता है हाँ हाँ ऐसा भी होता है. So it becomes easy when we gain the confidence of the patient and patient understands, and the complete rehabilitation is required in that situation. Even psychiatric help is required. We do send our patients to them.
Good afternoon, ma'am. Ma'am, I'm Dr. Sarvesh. Ma'am, I just want to discuss a small case, ma'am. A patient, she was having a persistent back pain and pain in bilateral hip joint area during pregnancy. Post-pregnancy, when MRI was done, she came out to be bilateral sacroiliitis, and her ANA was 1 positive, and uric acid was mildly raised, for which medications are given. So, ma'am, how to manage these patients who are having post-pregnancy sacroiliitis, ma'am?
As I told you that during the peripartum stage, there are studies which show that those patients can have changes suggestive of inflammatory low back pain. They can have bilateral sacroiliac inflammation, which usually subsides over the weeks and the month. But if the problem started only postpartum, then we have to be very, very careful. One. Second, I have seen cases developing sacroiliitis which was infectious, because infection from pelvic area to go to these joints, and those patients, they respond very well to antibiotics. And MRI, usually if we are getting soft tissue inflammation also along with articular changes, then that suggests that it could be a possibility of infection. Regarding ANA, there was no indication for doing ANA in these patients, because ANA we do only when we suspect connective tissue disease or secondary vasculitis and not getting the clue. In patients where we are suspecting spondyloarthritis, we don't do, because all autoantibodies can be positive in various proportions of patients, more in females than in males, And post-COVID, we are seeing lots of patients who are having various autoantibody positivity without any clinical significance. So these autoantibodies are to be ordered only when they fit into our clinical diagnosis. That's one. Second, this patient can be treated symptomatically with non-steroidal anti-inflammatory drugs, and maybe she will not develop, she can regress, all manifestations regress.